Good evening, everyone. Welcome to today's Masterclass. Today is the 55th chapter in the series of Masterclasses brought to you by IASO Academics. I invite Dr. Sharad Desai, our President-elect, to kindly deliver the welcome address for today's session and open the session. Sir.
Thank you, Srujan. Good evening and welcome everyone to the fortnightly online educational activities of the Indian Association of Surgical Oncology. The master classes, as you all know, are very enthusiastic and they are a high-reaching activity for all the surgical oncologists all over the country and especially for the students. And IASO is indebted for the support, unwavering support, which you have all been giving to the master classes over the last 4 years. The topic for today is early breast cancer. It's subject of great interest for every surgical oncologist and a disease which is highly prevalent. The students will be introduced by Srijan and they will be challenged by Dr. S.V.S. Dev sir, who does not need to be introduced. But then, for the sake of formality, let me tell you that he's one of the finest and the brilliant mind in as far as breast oncology is concerned in our country. He was previously the chair of the head of the Department of Surgical Oncology in AIMS, now is moved to Apollo Hospital from Delhi. He is supported by Dr. Neeta Nair, a dedicated breast cancer specialist and a well-known person in breast oncology, and she comes with the powerful tag of the Tata Memorial Hospital, Mumbai. And finally, my friend, my senior, Dr. D.G. Vijay sir. He's a very well-read and a very soft-spoken person and a famous personality in my education time. Dr. Vijay presently is working as a chief of the Department of Breast Oncology in SCG Ahmedabad. So I now request Dr. Srijan to take over ahead the proceedings.
Thank you, sir. The examinees for today are Dr. Nishta, who's a resident from the Institute of Kidwai Memorial Institute of Oncology from Bengaluru, and Dr. Manthan, who's a resident from Dr. B. Birua Cancer Institute, Guwahati. I would like to thank both the residents for volunteering to attend as examinees for this session. I would request them to enjoy this session as much as possible. For the other online participants, please note that on YouTube, you'll also be able to find a lot of breast oncology related webinars which have happened in the last 3 years. We have early breast cancer, locally advanced breast cancer, hereditary breast cancer, carcinoma in situ breast, and recurrent breast carcinoma, which you can go through later as well and try to learn as much as possible. Few instructions for the session. To our moderator, Dr. D.G. Vijay, I kindly request you that you please address the examinees by their names to avoid any confusion between the two as to who is supposed to answer, and also to ensure that both of them get equal opportunity to answer and take part. To our examiners, because this is a mock exam and not an actual exam, so in interest of both the viewers who are online today as well as viewers who are viewing this later on YouTube, we request you to give the expected answers to the questions that have been incorrectly answered by the residents or remain unanswered at the end of examination. To our examinees, if you don't know something, just pass the question along. You are never expected to know each and every question in an exam. It will save us time and maintains the flow of this online pattern of interaction. And be in the habit of taking the hints which the examiners keep giving by their voice, by their tone, by their facial expressions, and they are leading you to answer correctly as well. For the participants, we thank the senior ISO members who we see online who are joined in. Please post in your inputs in the chat box as well. And the residents, take this opportunity by both hands and clear all your doubts. This is attending live is always better because you can clear your doubts right today, right now. With that, I request Dr. D.G. Vijay, our moderator, to kindly share his screen and get the mock exam going. Thank you, everyone.
Okay, thank you, Srijan. Let's set the ball rolling. Hello.
Yes, Vijay, you are audible.
Can you see the slides?
No, we can't. We need to share them.
I thought we had shared the slide. Srijan, can you share the slide from your end?
One second, sir. If you can keep trying, I'll try to get them online from my side.
Yeah. I thought we had already shared it with you.
It'll take me 2 minutes, sir. If you can get started by introducing the first case, I'll get the slides up in 2 minutes.
Yeah.
We can see your slides.
Yes, yes.
Okay,
Now
now-
we can see the slides. Yeah.
So, yeah. We are very lucky to have a very elite panel of examiners with me, Professor Dev and Nita Nair. And I wish both the examiners, Nishita and Manthan, all the best. Let's get the ball rolling because we have a long 1 hour in front of us. Yeah. So this is the first case. She is a 60-year-old female with a right breast lump since about 4 months, no other symptoms, no medical comorbidities. She had her menopause at about 47 years of age, her menarche at about 12 years, P2, L2, and history of having used oral contraceptive pills for about 6 years. And there was nothing contributory in her family history. So my first question to Nishta is anything else that you would want in this history before we go on to the next slide?
So I would like to know the obstetric history of the patient, whether she breastfed her offsprings and what was the age at which she had her first pregnancy, because that would point out towards a risk of small risk, but a risk of breast cancer in the near future.
Okay. So, Dr. Dev, any thoughts on breastfeeding, and you want to ask any question to Nishta?
Yeah, absolutely. So here you're talking of the age of first childbirth. That's what you mean to say?
Yes.
Yeah.
Okay. So what is the general cutoffs to increase the risk? How do you define early age of menarche or age at first childbirth? What is the cutoff?
So the age at first childbirth less than 30 years is a good factor, and more than 30 years is a relatively high risk factor. Menarche, the normal menarche is defined between 9 to 16 years. So anything before that is early menarche. And if menarche is happening within 3 years of the thalaki, then also it's normal itself.
And breastfeeding for how long do you think is protective?
So 6 months of exclusive breastfeeding, and then there is a cumulative effect up to 1 year that benefits the patient.
Okay.
Nishta, I'm just going to correct that
Yes.
once. It's 12 months that you'd want them to have breastfed, because that's what reduces risk by 4%. You've talked about menarche, you've talked about breastfeeding and age at first childbirth. Would you like to also talk about menopause? And I still feel that there's one thing in the history that we could get more information from, which you haven't asked for. Is there anything else you can think of?
History of oral contraceptive pill
So
use.
that's there. It says no history.
is there.
So the history is there for 6 years. Is there anything else that you'd want to know?
Any history of breast biopsy in the past?
Okay. Anything else? She achieved menopause at 47. She's currently 60 years old. Is there anything else you'd want to know?
I'm not sure.
So you may want to also rule out
History of-
there's no hormone replacement.
Hormone
therapy
replacement.
given, right? So why is hormone replacement therapy important for us to know?
Ma'am, because hormone replacement therapy too is associated with a relative risk of around 1.6 in breast cancer. So if she's had a
Any specific hormone replacement therapy or
estrogen, if you give estrogens in the hormone replacement therapy, then they're associated with a higher risk of breast cancer.
Manthan, would you like to add to that?
Combination hormone replacement therapy is more associated with highest risk compared to other form of hormone replacement therapy.
Correct. So actually the higher risk is seen with combination hormone replacement therapy, estrogen plus progesterone, and women who had had a hysterectomy and were given estrogen alone did not have an increased risk related to incidence of breast cancer. For anyone who wants to read that up, you may want to look up the Women Health Initiative study, which was published years ago, and there's an update from that, which explains that. Sir, back to you.
Yeah, Manthan, can we go
Yes,
back,
sir.
Vijay? Just
Yes, sir, of course.
previous slide. I have a question for Manthan. So in the family history, non-contributory. So what kind of family history would you like to elicit in this patient?
I
This
think
is
the
the
next question, the next case that we have, sir, is
Focuses on
has a
that.
strong
sir.
All
family
right, all
history.
right. So we can pass it and we can move.
Yeah,
No
so
problem. Yes, we'll move to the
Manthan,
next.
so she is ECOG PS1 and she has a 2 centimeter mobile lump in the lower outer quadrant. The skin and the pectoralis major muscles are free with no palpable axillary nodes. And I will examine the patient for you and the contralateral breast and axilla. So basically, she has a 2 centimeter mobile lump in the lower outer quadrant of the breast, and the rest of the examination is normal. So I think in the history, Dr. Neeta and Dr. Dev, I would also be interested in knowing the body mass BMI of the patient, because that is a very important factor. Manthan, any thoughts on BMI and breast cancer?
Yes, sir. BMI, the high obesity is a known risk factor for the breast cancer, because in the postmenopausal period, there is the peripheral conversion of estrogen happen only in the peripheral tissues. So, if the patient is BMI is high, then there is high exposure of the estrogen in the postmenopausal period, which lead to increased risk of breast cancer. And
Agreed. Just to complete that, is that postmenopausal weight gain is primarily what increases risk.
okay.
Nishta, what is the next? What are the three components of triple examination?
There are detailed history and physical examination, then imaging, and
So what imaging would you want in this patient?
so in this patient, I would like to go ahead with the digital mammogram. I would like to do ultrasound as well as an extension of my clinical examination.
Yeah,
with
that's okay. Okay. So this is the mammogram for the patient. Could you, Dr. Dev, you would want the examinee to read the mammogram?
Yes, sure, please. Yeah. Describe the mammogram, Nishta.
First of all, I would like to comment upon the adequacy of the mammogram. So I can just see the MLO views of the patient. There should be an image annotation describing the patient details, and along with that, there should be an image marker as well, which will tell us that which is the upper part and which is the lower part on the mammogram. So I feel that the films are inadequate slightly. And so moving on to the mediolateral oblique view. So then further, I would like to comment upon the further adequacy in the sense that the pectoral muscles are unequally visualized on the both sides, and the pectoral muscle on the left side appears to be
Could
slightly
you just
higher.
concentrate on the positive findings of this particular mammogram instead of describing its inadequacies?
Okay,
Positive
sir.
findings, please.
Sir, first of all, the breast density. So it looks to me like a ACR B to C breast. And I can, then moving on to the mass, I can see a small, roughly one centimeter mass in the breast, which is having spiculated margins. There is no architectural distortion in the breast. The nipple and the skin appear to be normal, and it is a hyperdense lesion. Uh, and I can see some axillary lymph nodes, but they look normal too.
Okay, very good. So you are right, in ACRB, grade B, well-defined lobulated high density mass. I think it turned out to be 2 centimeters in size at about 8 o'clock in the right breast, and it was classified as BIRADS 4C. So,
Vijay,
yeah.
Can we just go back to the clinical examination? I have one or two questions for the candidates.
Yes, sir, of course.
Just before we move on to the imaging. Yeah.
Okay, just this one, next one. Yeah, this one. Okay.
Yeah, this is fine. Yeah. So anything else you would like to know in the clinical examination as a postgraduate at MCH level? Are you happy with this description? Would you like to add or elicit anything else?
So I would like a mention of the breast size as well.
Very
Uh,
good.
whether and the cup size of the breast as well. So there
Good.
is a mention of the supraclavicular fossa, but there's no mention of the infraclavicular
So
fossa.
why is the size important? What is the
So,
relevance?
The size helps us to decide the extent of volume that will be removed from the breast, and it will also help us to guide towards the oncoplastic procedure that we intend to plan on or not.
How is the
Okay.
ptosis important?
So the ptosis itself is a guide to the oncoplastic procedure that we intend to perform. Because if the ptosis is more, then we will need a nipple symmetrization procedure, or we'll need a procedure in which there may be a procedure in which one nipple goes up and the other does not. So it may demand additional procedures as well.
So Manthan, what is grade 2 ptosis?
Sir, ptosis grade 2 is where the level of nipple is below the inframammary fold.
Okay.
Grade 1 is where the nipple is at the inframammary fold, 2 is below it, and but it is not the most dependent part. And grade 3 is where the nipple is the most dependent part.
Good. Anything else? Both of you, I have one more question. Anything important finding in the
Sir, if I
yes,
can just ask
yes,
one
Nita, please,
question.
please.
Yes, ma'am. Please.
Manthan, I'll give you 5 points extra if you can describe what is
Yes.
pseudotosis.
Yeah.
Pseudotosis.
What is pseudotosis?
Okay, so while you're talking about grades of ptosis, you must also know what pseudotosis is, where the nipple is at the right position, but the lower pole of the breast is very heavy and looks like it is ptotic, and it is below that. So the nipple is still at the level of the IMF, but it's just that the lower pole is heavy, right? Do you know whose classification this is?
This is
Renault classification.
Yes.
Yeah.
Perfect.
Lovely. So,
Vijay,
Manthan, yes, sir.
Please, Vijay, go ahead.
Manthan, your colleague mentioned that the density of the breast is very important. How do you think the density is important as far as selecting the appropriate oncoplastic procedure?
Sir, there are 4 types of density. So density is important as how much the fibrogangliodar tissue is there. If there is
just tell me, what would you do in a fatty breast? What would you avoid doing in a fatty breast? And what will you do in a very fibrotic, with a lot of fibrous tissue? Is there any difference in your approach?
Yes, sir. In the fibro-dense breast, we can mobilize tissues better with less chance of necrosis. So we can go ahead with the type 1 oncoplasty better if the breast is of higher fibrogangliodar tissue. And it is more of fatty, then we have to, we can't mobilize much of tissue, and we have to go for, if required, then type 2 oncoplastic surgery, sir.
Good.
Okay.
So just one last clinical finding. I'm still stuck at clinical assessments.
Yes, sir. I'll go back. I'll go back.
No. It
Yeah.
is just a question to both of the candidates. So what is the relevance of nipple areolar complex? Would you like to describe nipple areolar complex, the size or anything else in the breast patient?
Yes,
Yes.
sir.
NAC?
Status of the nipple.
We missed out on the
State-
nipple areolar complex.
Yes. So NAC you need to describe, and also the diameter of NAC is important sometimes in planning your surgery, and the distance of the tumor from the NAC is also important sometimes if you're planning a donut approach or a periareolar approach. So these are important. So just try to remember as a MCH or a DNB student, when you describe your clinical assessment, it should include your size as well as NAC and the coordinates of the tumor from NAC. That's it. Vijay, we can move to the imaging, please. Yeah, please.
So, sir, before you move beyond the imaging,
Yes.
Nishta, when you described that view, you should have asked Dr. Vijay to show you both views. It's very important for you to insist on seeing both the CC and the MLO view before you start describing the tumor, because you want to be able to give the quadrants based on that, and you cannot do that without seeing both views. Go ahead, sir.
Sometime during this presentation, I feel that I am the examinee rather than the examiner.
To be fair, when she said things were
No,
left,
I agree. I
think
agree.
we cut that out specifically.
Nishta pointed out so many inadequacies.
Yeah.
So this was prepared last night in a flurry of activity. So
No,
we,
Vijay.
Yeah.
Vijay, these are just the templates.
yes, of course.
These
of
are
course.
templates because
You
we are
know my
asking
sense of
fantastic-
humor. So this is,
yeah.
but I think the students are doing really very well. Let's
Yeah.
quickly move on to the management part.
So,
So,
No, we'll
uh,
can we
just
go
spend
back a
little more
slide?
on the imaging.
Yeah.
yeah,
Yes, Neeta, please.
So, Nisha, you commented on the axillary lymph nodes and that you thought they looked significant. What would you actually like to do to evaluate the lymph nodes?
Ma'am, I would like to do an ultrasound of the axilla to comment upon the possible suspicion.
What
of
are the
malignancy.
factors, Manthan, that you would look at on an axillary ultrasound, which would suggest
Axillary-
that the node is
Yeah.
suspicious?
For the evaluation of axillary lymph node on USC, I would like to see the first is the shape of the lymph node. Then there is preservation of the fatty hilum or not. There is echogenicity at the center for any necrosis is there or not. Vascularity of the lymph node and the margin and borders of the lymph node. I would like to see.
Else?
Very good.
What cortical thickness would you call
Yeah,
suspicious?
cortical
So what
enhancement.
cortical, so
What is
what
the cutoff?
cortical thickness? What is the cutoff?
Don't know exactly, ma'am.
Nishtha, would you like to take that?
I'm not sure, but I think it's 5 mm, but I'm
So
not
it's
sure.
about 3 millimeters.
3. Yeah.
So anything else?
Dr. Dev, anything else before? So the right axillary nodes
Yeah.
were mildly thickened. The left breast and the left lymph nodes were. Yeah. Yes, sir. Yes, sir.
I think his internet is giving trouble.
Okay. So, Nishtha, before we move on to the next question, a very simple question is, why was the system of BIRADS, do you think, introduced?
So that we could have uniformity in the reporting of the mammography.
Excellent answer. Because, about 25, 30 years ago, there used to be long descriptions of mammograms, which at the end of reading, you didn't know whether the tumor seen on the mammograms were benign or malignant. Now, the American Radiology Society is what actionable guide, BIRAD. So, you know what to do at one, but we don't go into that today.
So I'm actually going to ask, what is the full form of BIRADS?
Pirates.
Breast
Breast imaging.
imaging reporting and data system.
Yeah.
So,
Yes.
Manthan, now you have the mammogram, you have that this ultrasound appears to be indeterminate. The left breast is absolutely normal. So, as part of the triple assessment, what would you want to do now?
First, we would go for core needle biopsy of the right breast lump.
Okay.
And then we send for the biopsy with the IHC for the ER/PR HER2/neu and Ki-67 index. Would like to evaluate that first for the
Okay.
confirmation of diagnosis.
Excellent. So this turned out to be invasive ductal carcinoma, grade 2. She was ER/PR positive, HER2 negative, with a Ki-67 of 15%. Because the nodes were inconclusive, we also did an FNAC from the right axillary node and the left axillary node. They all turned out to be reactive lymphoid hyperplasia, and she was finally staged as T2N0. What would be the metastatic workup in this patient? Manthan.
For these patients, sir, there is less chance of distance metastasis, so we don't need
How much chance? What are her chances?
less than 3%, sir.
Okay.
Chest X-ray and USG abdomen is the maximum I would like to do. No role of CCT or and bone scan, unless the patient is symptomatic.
No, she has no other symptoms.
Nishtha, I'm going to ask a slightly different question. What could factor in the history or the findings could change your need to want some imaging in this patient?
Ma'am, contralateral positive.
No, so contralateral positive axilla, fair enough. Anything else? So let's say it was not where it is located and it was in another location. What location would push you to want additional imaging?
Towards the
You can
axillary.
tell us the answer.
Okay.
So
So
that,
if you have an
yeah.
inner quadrant tumor, you have a higher probability of having internal mammary nodes. So Manthan, do you know what the incidence of internal mammary nodes in axillary node negative patients is?
4%.
For inner quadrant?
4%.
So it's about 15%.
Isolated.
So it's about 15%.
15 for inner
And
quadrant.
if the axillary nodes are positive, it can go up to as high as 35% in an inner quadrant tumor. So if you have an inner quadrant tumor, you may be justified in asking for a CT scan to evaluate or stage your patient correctly for internal mammary nodes. Right. Thank you, sir.
So coming back to Nishtha, so now you have a clinically T2 N0 lower outer quadrant, adequate breast volume, elderly female, hormone receptor positive. So you counsel the patient, I believe, for surgery. And what is the surgery that you are likely to advise her?
Sir, after discussion in a multidisciplinary team and assessing what the patient expectations are, in this case, if she is willing for a breast conservation surgery, we can consider the patient for a breast conservation surgery.
Okay.
Would you like to add a
yes,
little to
yes.
that?
So I would also like to address the axilla with a sentinel lymph node procedure.
Okay.
Anything else that you'd want to talk to the patient about before you discuss breast conserving surgery with her?
Yes, the need for mandatory radiotherapy. So her logistical constraints should be dealt with before we give her the plan of breast conservation surgery. And because she is ER/PR positive, so she will require post-operative adjuvant.
We'll come to that. We'll come to that.
We'll come to that. So I'm going to ask you, we'll come to that in the adjuvant actually. Go ahead.
So just, I have a question to Manthan. What are your absolute contraindications for breast conservation in the current era?
First is the inflammatory breast cancer. Second is the pregnancy.
Pregnancy is absolute
Pregnancy is
contraindication.
a relative contraindication. Absolute is inflammatory breast cancer, multicentric cancers.
Multicentric is absolute
Also
contraindication.
relative.
No.
Relative contraindication. Absolute is inflammatory breast cancer. When the margin is comes again in after 2 re-excisions, the margin is positive. Then it is contraindication. Patient is not willing for breast conservation, and
Nishtha, would you like to
widespread
add?
widespread
Absolute-
calcification
absolute
present in the
contraindication.
mammography.
Diffuse extensive microcalcifications or diffuse extensive DCIS, which prevents the us from giving a proper cosmetic outcome. And if even after post-neoadjuvant chemotherapy, the tumor breast volume is not adequate such that a large volume of the breast will get removed, then we'll have to go ahead with
You're missing one. You're both missing one.
Yeah. Absolute.
There are only 3 absolute contraindications. Everything else is relative. The first was inflammatory breast cancer. The second was persistent positive margins. Now you need to tell me a third. Radiation therapy. Patient's ability to take radiation therapy. Right? There has to be, she cannot have had radiation before, cannot have other pre-existing conditions because of which we cannot give her radiation. Everything else that you mentioned falls more or less under relative
control
indications now with the oncoplastic techniques that we have.
So what is the relationship with collagen vascular diseases, history of collagen vascular diseases? Is it a absolute contraindication? No.
It is a relative contraindication, sir. When there is history of collagen vascular disease, after giving the radiation, there is extensive chance of extensive fibrosis is there, and the disease can exaggerate. So it is relative contraindication to radiation. So because breast
Any specific collagen vascular diseases you have to be specific, because collagen vascular is a wide spectrum.
Scleroderma and SLE.
Yeah. Scleroderma and lupus. Yes.
So
yes,
for,
please.
Yeah. So we will move on to the actual management, Nishtha. So this patient underwent wide excision with sentinel node biopsy. So which are the three methods that are commonly used and the method that you use at the Kidwai Institute for doing the sentinel node biopsy?
So we can use ICG, then we
Yeah.
can use blue dimethylene blue, and then we can use a radioactive technetium-99 colloid for sentinel lymph biopsy.
Is it necessary to remove the overlying skin as demonstrated in this particular photograph?
So probably that would be the biopsy scar that has been taken out with the margin. So
Excellent.
for
So
the
you don't need to remove the overlying skin, but you just need it to get adequate exposure probably, and as a skin marker, and because you can always mark the base of the tumor. Okay.
Vijay, I would like to ask
Yeah.
Nishta a question. How do you plan your surgery in breast conservations, margins? What are the principles of surgery? How do you make sure that you are excising a margin negative tumor?
So by clinical palpation intraoperatively, we take a 1 centimeter margin, and that is the main thing.
So palpation
Or
guide-
three-dimensional.
Yeah,
Palpation
three-dimensional.
is one method.
And
Anything
we
else?
have to go down to the pectoral fascia, and we have to take the pectoral fascia along with the specimen.
Is it mandatory in all the patients to include skin and fascia?
No, it is not a absolute thing.
It is not absolute mandate. If it is in the mid depth of the breast, you have a good parenchyma, you don't have to go deep up to the fascia. All right, just make sure you take 1 centimeter palpation guided margins. So do you do routine frozen sections or anything required for assessment of margins?
Yes, sir.
Make sure.
We do frozen sections, and sometimes we do.
What is the evidence for frozen sections currently? Is it routinely recommended for all
Hey.
breast conservations?
If we are confident with our margins, then it is not recommended. But
Okay.
a specimen mammogram should be done to see we have removed the entire disease and the microcalcifications.
No, in this particular instance, there was no microcalcification, but you are
Yes.
right. Okay.
So I'm going to ask you a question, which is, what do you think are the margin positivity rates currently in the country at most average centers? So, okay, I'll tell you it's about 4% at some of the largest centers. And this is by palpation only. So you mentioned frozen section is one way to reduce the margin positivity. Is there something else you could do? One was a specimen X. Anything
Cavity
else?
save margin.
Intraoperative,
Cavity shave.
Cavity
all
save
right.
margin.
Yes.
intraoperative
Anything
USG.
else? So USG of the specimen. That's a third
Intra-
thing that you consider. Fair enough. And how do you mark a lumpectomy specimen?
Nishta, Manthan, go ahead. Yeah, Manthan, go ahead. How do you mark a lumpectomy specimen?
First, after the removal of the specimen, we also mark the cavity with the clips for radiation. For the specimen purpose, we orient the specimen one thread on the superior side short and one long on the lateral side. And if skin is not removed, we also mark the base.
With ink, black ink. Okay.
Yes, black.
Can we move on to the next
Yes,
discussion?
please.
Yeah. So I believed Nishta and got a specimen mammogram is irrespective of the fact that this patient didn't have microcalcification and it showed. Do you think, Nishta, that the specimen has been appropriately excised?
Yes, sir. There is significant margins on all sides. So,
And you don't see any microcalcification at any of the margins. They appear to be. So the clips are also single clip superior, 2 clips lateral. So it appears to be free from all the margins. So the wide local excision invasive carcinoma, the final tumor size 24 by 15 millimeters. Because we want to run through 2 cases, we will go a little rapid now. All margins of resection are free, and 2 lymph nodes were identified with using the ICG technique, and both turned out to be negative. So Nishta, again, I suppose you do frozen section for the node as well as for the margins.
yes, sir.
Okay, so on frozen section, they turned out to be negative. And on the final paraffin section, they turned out to be negative. So,
So, sir,
and the
before you
wound
go
has
ahead,
healed well.
so if you go ahead, before you go ahead, I'm going to ask two questions.
Yes.
Manthan, what is a negative margin defined as?
Negative for invasive breast cancer, it is negative, no tumor and on the ink of the margin. It's taken as a negative.
And for
So,
DCIS?
Sorry, DCIS is 2 mm. Less than 2 mm is marked as positive.
so
Right.
what is this consensus called? Who defined this margin? Any idea? Nishta?
ASTRO consensus guidelines.
SSO, Astro, both combined.
Yes.
All right.
And
Okay.
I'm going to ask one more question. Would you be happy, and Dr. DG Vijay is going to hit me after this, but are you happy to see 0 out of 2 lymph nodes? What is the false negative rate of sentinel node biopsy with every increasing node? So do you know what the false negative is if you have only 1 node identified and if you have 2 nodes identified? And what is the most appropriate number of nodes that you'd want to find?
Most appropriate would be more than 2 nodes.
Right. So 3 nodes.
3 nodes, more
Right.
than 2 nodes, 3 or more than 3.
So what is, Nishta, do you know what the false negative rate in any of the literature is with 1 node identified?
It is more than 15% if just a single node is
So it's about,
identified.
correct. So it's about 17%.
Yes.
But
Uh,
now I'm going to ask you, this patient comes to you after having been operated by Dr. DG Vijay. You see 0 out of 2. Are you going to go back in to take out 1 more node? Or are you happy to accept this?
I would not go ahead with an additional surgery because we have to individualize our patients to the treatment we are providing to them. This is
Can you give me one more reason on why? Sir mentioned he used ICG. What else do you think he did?
he would have done a second. He would use a dual technique for.
So he's used ICG. ICG is fairly good despite being a single dye technique. What else do you think he did?
He sent it for frozen as well.
That's still 2 nodes.
Palpated the axilla
He
while
will
doing
have
the SLND.
palpated the axilla himself,
Hmm.
right? So if you see the NACBP B32 study, 2.3% of the nodes identified were by palpation alone. So sentinel node is no longer just the dye-stained node, but also palpation of any additional nodes. So which is why when you get it from an expert like him, you know that he will have done that. And you're comfortable with the fact that you also had an FNAC prior to the surgery, which told you that it was all negative. Right? Go ahead, sir.
Sunita. But
So what is the current recommendation of sentinel node? What technique is ideal?
Dual dye techniques is ideal if facilities is available. Radiopolloid technetium 99M with blue dye or ICG, whichever is available.
So what is the acceptable false negative rate?
So there should have been a validation study at the institute and by the surgeon who's performing it. So at least 20 or some say 30 cases should have been performed with a false negative rate of less than 5%. So
Right.
after we've done the validation study, validated our data, then we can proceed. Less than 5%.
All right, very good. Dr. Vijay, please go ahead.
so
Yeah, sorry.
we already discussed this about single dye, dual dye, ideal site for dye injection. Nishta, quick answer.
Please.
All techniques are equivalent, but subareolar is the most
Where do
preferred
you
one.
inject?
Subareolar.
Very good. And what are the false negative rates with single dye, dual dye?
So with the experienced surgeon, they are less than 5%.
Okay.
So
And
any specific site of injection with ICG?
Intradermal.
Subareolar.
Intradermal gives the
Intradermal.
best results.
Best result.
Yeah.
Also, you have to be very careful in walking a thin line in not removing a lot of non-sentinel nodes, because that defeats the very purpose of doing a sentinel lymph node biopsy. So once you standardize your technique, then you make sure that you remove only the adequate number of nodes, 3 or 4 maximum. Yeah. So my next question to Manthan is, now that she's clinically T2 N0, 60 years, hormone receptor positive, HER2 negative, Ki67 15%. So what is the adjuvant treatment that you are planning for this patient?
First, this patient will receive the adjuvant radiotherapy, and along
Adjuvant
with
systemic treatment.
adjuvant systemic treatment, followed by adjuvant radiotherapy, and along
What
with
systemic
radiotherapy,
treatment?
systemic chemotherapy, sir.
Nishta,
So,
the
it's
ball is
similar-
now in your court. She is an elderly lady, 60 years, hormone receptor
Hormone.
positive. What do you do?
Hormone.
So we would like, if we have the facility, we would like to do a recurrence score assessment with Oncotype DX. And if the facilities don't permit, we have online scores like Predict Online, which can tell us how much the risk is in the next 10 years. And based on that recurrence score, we can decide whether to give chemotherapy or not. If she's a low risk category, we can proceed directly with the endocrine therapy for 10 years. And additional, we will give her adjuvant radiation for the loco-regional control.
I'm going to intervene here, Nishtha. One, Predict as an online tool gives you risk of death, not of recurrence. And two, if you read a paper which was published by Dr. Sudeep Gupta and me, in an Indian population, Predict overestimates death, and it's actually not validated. So use it with a little caution in the Indian group. So you want to ask for a recurrence score that's fair. There are 4 recurrence scores in the system, of course, Oncotype DX being the best. And in a postmenopausal lady, that's something that you'd be comfortable to advise. Your patient cannot afford anything. Is there any other test other than these recurrence scores, which are gene profiling, that you can offer to your patient? Do you know of any other algorithm?
Can assist.
CanAssist is also an IHC-based
It's
recurrence.
also is.
Okay.
Tell me something else. So I'll give you a hint. Have you heard of Dr. Mike Dixon? He's an extremely well-known pathologist in the UK.
IHC.
IHC4
IHC.
clinical score. So it
IHC,
uses
IHC.
ERPRH score, which means your pathologist has to do much more work to give you an ERPR scoring system. And then you use other clinical pathological characteristics, and then it gives you a recurrence score based on an algorithm. So if your patient cannot afford anything else, you get your pathologist to do a little more work and get involved with that. Right? So you mentioned your patient's going to take hormone therapy if she's low risk. What hormone therapy are you offering this lady?
She's a post-menopausal lady. So after her dental evaluation and bone mineral density evaluation, I can proceed with aromatase inhibitors.
Right. And how long would you like to give the treatment?
For 10 years.
Is there any evidence for aromatase inhibitors for 10 years? Manthan?
Some studies has done like MA17 study, but they have not recommended use of 10 years. They have shown that the benefit is there is no extra added benefit of prolonging the aromatase inhibitors for 10 years. So right now recommendation is only for 5 years.
Okay. So Nishtha, would you like to add anything to that before I correct that? So MA17 are ideal data, NACBPB31. There are 2 more I can name. All of them are very heterogeneous in their data, but the current recommendation is a maximum of 7 years for aromatase inhibitors. There is some evidence to suggest that if your patient is low risk node negative, you evaluate at 5 years based on whether she is tolerating the drug to extend to another 2 years, right? So if you're giving your patient an aromatase inhibitor, she gets it for up to about 7 years.
So, Manthan, that is the point that the experts were trying to make, that the incremental benefit of adjuvant chemotherapy in an elderly patient, hormone receptor, node negative. So that incremental benefit of adjuvant chemotherapy is very small. So before you advise, she could, of course, she was in excellent performance status. She could also have a lot of comorbidity. So please weigh all those factors before you decide to go ahead with chemo. So
I think Srijan's reminding us we have only 20 minutes.
Yeah.
I'm going to ask
Yes.
one question on radiation before I hand back to Sir. Manthan, any evidence to omit radiation in this lady?
No, ma'am.
Nishtha?
In my knowledge, there is no
There
evidence to
are
omit.
2 trials, ma'am. One is the CalGB 9343 trial, but the size recommendation in that was 2 centimeters and age was more
But
than
under
7.
3 centimeters. So both are actually above the age of 65. So one is
Yes.
65 and above, one is 70 and above. And looking at avoiding radiation, that's PRIME 2 and the CalGB study. One last question. Your patient had an axillary node which you FNA'd, which was negative. Any role of avoiding axillary surgery at all in this patient?
We
Manthan.
have
If we are planning to do BCS, anyway, we are going to give radiation to the breast. So we can irradiate the axilla along with it
So that you're talking about if the lymph node comes positive.
positive.
Nishtha?
Yes.
And we have
MRS
data
trial.
from the sound trial which suggests that observation if the nodes are clinically negative on ultrasound, we can omit any
So are
form
you
of axillary.
currently practicing that at your center?
No, ma'am.
Can you give me one reason why?
Ma'am, because we rarely come across tumors that are less than 2
But
centimeters.
let's say you come across a tumor that's less than 2 centimeters.
Our follow-up is also not that.
So there are 2 things you need to keep in mind. One, the sound trial median tumor size is 1.1 centimeters. They're low-grade tumors, older patients. And the second thing is heterogeneity of ultrasound reporting in our country is a reality. So you need to be a little careful about how you interpret that. This lady did have an FNAC, so that was something, but the tumor size is much larger. So sound trial is not something you can adopt so easily. Thank you, sir.
So we move on to the second case a little quicker now. She is a 28-year-old female with a left breast lump since 4 months. No other symptoms, obviously, no medical comorbidities, premenopausal, menarche at the age of 12. We've already gone through all this. She is nulliparous, and this is her genetic history. And okay, Neeta and Dr. Dev. Anything, Dr. Dev, you have done a lot of work actually in genetics and breast cancer and published a lot. So anything in this particular tree and any questions on genetics and breast cancer? Maybe 2 or 3 quick questions.
Yeah, Nista, can you tell me what are the red flags
Uh,
digging deep into the genetic history? So when do you think of going for a genetic counseling or a testing in your routine clinical assessment?
So, 28-year-old lady is a factor for genetic testing. Then a strong family history, more than 3
28
relatives.
means any age cutoff
Yes, sir.
as per the current guidelines? Yeah.
Yes, sir. Any female less than 45 years, triple negative breast cancers less than 60 years,
Yes.
strong
Yes.
family history of more than 3 relatives diagnosed with breast or related cancers like ovary and
Yeah.
prostate and pancreas in the family at any age, and 2 first degree relatives diagnosed with breast cancer less than 50 years of age, diagnosed less than 50 years of age.
Anything else? 2 more.
For genetic testing.
Yes.
If the female herself has a personal history of ovarian cancer,
Okay. One more.
and if there is a known mutation in the family that has been
One
treated.
more. Something from family history that's very significant.
Male breast cancer in the family.
Yeah.
Excellent.
Exactly.
Did you mention bilateral breast cancer?
Yes,
No.
bilateral breast cancer.
Okay. Yeah. So please go through that. It's a fairly exhaustive list of clear indications for genetic testing. And in India, because we see a lot of young women with breast cancer, we see a lot of women with triple negative breast cancer. And when we test it in our clinical setting, we really find a lot of women, not necessarily with BRCA1, BRCA2 mutations, but there are a lot of other mutations as well, which are not probably clinically relevant, so relevant today, but may be upgraded sometime in the future.
Yeah. So, Dr. Vijay, here I have a question for Dr. Manthan. So,
Yes,
what
sir.
percentage of breast cancers fall under familiar or hereditary etiology?
Around 10%, sir. 10%.
10%.
Or
So,
yes,
with the current guidelines, of NCCN guidelines, what you have described, you are able to pick up around maybe 70%, but still we can miss 20 to 30% of pathogenic mutations. All right. So that is what the new concept is coming, maybe unselected, random, all right, and direct testing of genetics in all breast cancer patients may actually show a higher burden. If you follow the NCCN guidelines, that is what it shows, maybe around 10 to 15% of pathogenic mutations. So what are the common pathogenic mutations, Nishta?
So we have high penetrance genes, which includes BRCA1, BRCA2, P53, P10, then SKB11L, basically Peutz-Jeghers syndrome, and we have CDH mutations.
Good. PALB2?
SKB11, LKB1.
PALB2, yeah.
Yes. Then we have moderate penetrance genes, which includes BRIP1, PALB2, CHEK, and ATM. And then we have some low penetrance genes like FGFR receptor 3 and TOX3.
Okay, very good. All right, we can move Dr. Vijay.
Yeah, thank you, sir. So she has a 3-centimeter lump in the left breast upper outer quadrant with palpable axillary nodes. The rest of the breast is normal. Supra-infraclavicular fossas are normal. Her systemic examination is normal. You already mentioned that once you complete the clinical history, you would want a mammogram. So we run through that part as well. This mammogram, fortunately, is adequate by the definition of Nishta. So who described the mammogram last time? Nishta. So Manthan, can you please describe the mammogram this time?
Yes, sir. The mammogram showing
Quickly,
upper is
positive
the
finding.
caudal and there is a mass hyperdense mass seen with the speculated margins in the outer and lower quadrant, and there is axillary lymph node also seen on the left side, which is not very clearly seen. Around one lymph node is seen in the axilla.
Okay.
With normal skin, and there is dense breast, ACR grade 1 breast with a normal skin thickening.
Okay, we will quickly move on to...
So one question, Nishta,
Yes.
when would you ask for an MRI breast?
So we have screening indications. So if the lifetime risk of breast cancer is a high risk lady with lifetime risk of breast cancer more than 20%, a patient with a known mutation of BRCA or any of the high penetrance genes, then we have diagnostic indications like if we have a axillary node that is palpable and mammo we cannot identify a lesion. And we have then in patients who have implants to follow them up. And when we have doubt about if there is discordance between the ultrasound, between the imaging, in that case also, and when we have to differentiate between a scar and fibrosis in a follow-up patient of an average risk.
Post-BCS recurrence. So
Also
clinical
include
radiological discordance is the most appropriate way of answering. Under clinical radiological discordance would be ILC, dense breasts, etc. So those are not factors that you put up first. Excellent answer.
Excellent answer. I think very impressive. She had a core needle biopsy, infiltrating duct carcinoma, not otherwise specified, grade 3, ER positive, PR negative, and HER2 turned out to be 3+. Quick question to Manthan, is Ki67 important when she is already HER2 3+?
Yes, sir. Ki67 is important as to we can predict the response to the chemotherapy according to Ki67.
But that means you would be repeating the Ki67 on a repeat biopsy after giving her chemo?
No, sir. On the initial evaluation only.
So Ki67 is more important for endocrine therapy, monitoring of endocrine therapy rather than an aggressive disease like this. So Ki67 is expectedly higher in this case because it's a very aggressive tumor. So in this case, the FNAC was done from the left axillary node and it turned out to be positive. The rest of the metastatic workup. My question to Nishta, she is 3 centimeter, T2N1. Now, would you advise for a PET CT scan or not yet?
No, sir.
What's the evidence?
So PET scan is a problem-solving tool. So only when we have an equivocal finding and we need to confirm that finding, would we go ahead with the PET scan. Additionally, the quality of the CT scan that is done in a PET scan is of low quality, so it does not give us the findings. Plus, it also overestimates and gives us a lot of false positive findings, which might upstage the patient. And given we have a history, like our patients are predisposed to tuberculosis, so even a single node, say in the mediastinum, will
What
change
would
our
be your
management.
metastatic workup for this patient, T2N1?
No
Do you do a,
metastatic workup.
no, is there an indication for metastatic workup in this patient?
Early breast cancer, we don't do a metastatic.
Any exceptions?
If there are symptoms which are pointing out towards a specific system in that scenario, and if LFT we see an alkaline phosphatase which is elevated, specifically a heat labile alkaline phosphatase, we would go ahead with a CCT of the abdomen and pelvis, or a bone scan and a bone scan.
So, as per institutional protocol, young patient, aggressive disease, node positive,
I
we
would
went
like
ahead
to go for.
with a PET CT scan. It turned out that there were no distant metastasis and just confirmed, what we already knew before. So in the interim, we will just, I will discuss this and we'll come back to this in a moment, where her genetic testing was also done and she turned out to be BRCA positive. So I will just discuss this report in a short time. So my question to Manthan now, T2N1, ER positive, PR negative, HER2 positive. So what are you going to offer to this patient? Metastatic workup normal, neoadjuvant chemo, surgery.
Sir, a patient is HER2 positive, so I would like to go ahead with the neoadjuvant chemotherapy, sir. Yes, yes.
Before you initiate the chemotherapy, anything specific that you would want to discuss with a 28-year-old nulliparous young lady?
Patient can have amenorrhea following the chemotherapy because of the side effect of chemotherapy, and there are systemic side effect of the chemotherapy is also there. So would like to discuss
Would you
about
want to
the
discuss fertility preservation? What is, in your opinion, the best way for fertility preservation?
Your options are oocyte, embryo.
oocyte preservation.
So oocyte preservation, embryo preservation, or GnRH analogs. What is the best outcome?
Nishta?
Outcome-wise, oocyte preservation.
Both should be done. So we can do a oocyte preservation. If she has a partner, we can go ahead with embryo cryopreservation as well. And then we can give GnRH analogs prior to the start of chemotherapy and all along the course of chemotherapy to preserve the fertility.
Fine. So you must be aware that all this procedure of fertility preservation takes up a certain amount of time for the induction of ovulation to retrieve those oocytes and the subsequent processes. And so weigh the pros and cons versus her keen desire for bearing a child versus the disease profile. So all this needs to be discussed in a multidisciplinary team before you decide to do what you decide to do. Your thoughts on clipping, Manthan? Remember that she is a 28-year-old lady. So will you clip at the beginning of the chemo, after 2 cycles, at the completion of the chemotherapy planned regimen?
Before the starting of the chemotherapy, I would like to clip the tumor with radio opaque clips.
Of course, but at the center of the clip or at the margins of the tumor?
All around, both, sir.
One
all
clip,
around the
multiple
margin.
clips.
All around the margin and in the center also, sir.
Nishta?
Because
would you like to correct that?
Ideally, it is said that we should do it after 1 to 2 cycles of chemotherapy after we have seen the response. So that will help us better to clip the nodes. If there's a concentric response, we'll do it in the center. If it's patchy or a Swiss cheese type, then we'll do it around the edges. So it should be preferably done, but because of logistic concerns, we do it prior to the start of
I would also think that a T1, T2, small T2 tumor, if you start with it at the beginning, I don't think that answer was wrong, but
Yeah.
we want to place it at the center of the tumor, preferably.
Okay.
And
So,
also the node.
Yes, no answers. Nishta, you're HER2 positive, node positive, young lady, aggressive disease. Your chemotherapy options, TCHP, TCH,
TCHP.
AC. Oh, you answered that question before I completed your.
They are all out. I think they are, answering like a medical oncologist. Huh?
Correct.
Right, TCHP. Dual targeted therapy, huh? All right. Okay.
So, patients at HCG Cancer Center, Ahmedabad usually undergo TCHP.
That's where the rich patients are.
And as expected, she had an excellent response to NSCT. The tumor was, of course, clipped, but infertility preservation, oocyte preservation was done. Coming to Manthan, what are her surgical options? Right BCS, right MRM plus left risk-reducing mastectomy with or without reconstruction. Please discuss
there
this
are
very briefly for us.
we have to discuss this with the patient that she is a BRCA positive. So there is a chance of the breast cancer in the opposite grades in the future. So if patient is willing to go for risk reducing surgery, then we can go for right MRM with left risk reducing mastectomy plus or minus reconstruction. But if she is not anxious and a patient is willing to follow up on regular interval, the better option would be right BCS. With sentinel lymph
Is the
node.
BCS a contraindication in BRCA? And who said that it's not a contraindication?
Nowadays, it is not a contraindication, sir. The person.
I think the St. Gallen recommendations were one of the earliest people who said that we can go ahead with a breast conservation even in BRCA carriers. Okay.
Yes, sir.
Neeta, any questions on the surgical options?
I would like to make a point before that is just be very careful when you're offering a 28-year-old bilateral surgery, which is a mastectomy without reconstruction. Please keep anxiety and the fact that she needs to still complete her family, get quality of life in mind. So when it is not a contraindication, also please show enough empathy to discuss BCS and further follow-up. Anything else that you would want to be? So Nishta, you mentioned you were going to clip the lymph node.
Oh, yes, ma'am.
So what would you want to do after that to the axilla?
Ma'am, excellent response to NSCT. I would like to know whether the response is to the primary or is it to the node as well?
If the primary has responded, more often than not, the axilla will have. You'll never see residual disease only in the axilla.
Yes.
Very
So
rare.
if the axilla has responded and there is, we just have a clip node. So there are multiple trials which show that in a patient who has
Name
responded.
one randomized trial in a post-NACT N1 setting where you can do axillary conservation.
And we have the Sentina trial.
One randomized trial. There are none. So it's all prospective data. There's no randomized evidence for post-NACT N1 disease. So if you have access to targeted axillary dissection, having clipped the node, Manthan, 2 questions. How often is the clipped node not the sentinel node in post-NACT SND? One number. Nishtha.
5%.
30% of the time. Right? What is the current false negative rate, Nishtha, in Sentina for arm C, which is what this patient was?
Ma'am, if we have used dual technique.
Sentina.
I'm not sure.
14%.
14.
So what were the 2 ways in which you could reduce false negative rate?
So clipping the node prior to the surgery,
axillary dissection,
then removing at least 3 nodes and using a dual technique.
Yeah.
How often in either of the studies, Alliance or Sentina, were more than 3 or more nodes removed?
I don't know the exact.
Manthan?
60% cases. 60% cases.
Less than 40% of the time. Right? So in a post-chemo setting, when your nodes all respond, you may often not get yield that is adequate.
So
Right.
these are very important trials, Sentina, SNFNAC, Alliance. So you must really know all the details. Also, the clinical trials that justified the use of trastuzumab in a neoadjuvant setting, the use of pertuzumab in the
Dual
neoadjuvant.
targeted.
Yeah, dual targeted therapies. So all those details, they are landmark trials, and every single detail of them has to be at the tip of your fingers.
Yeah, Dr. Vijay, I have a hypothetical question to both the candidates.
Of course,
Suppose
sir.
patient achieves a complete response, clinical response, both imaging, clinical. So she will come back to clinic and say, can I just avoid surgery? What's your answer?
No,
Till now,
Evidence of
not recommended.
Ishta, yes, no.
no.
No. So
No,
what
sir,
is
no
current?
recommendations.
So what is the status? Any literature emerging on this? Can you
I
avoid
don't
surgery?
know the name. I can't recollect, but
recent
it's
trials published?
15% local recurrence if we go for observation just with radiation and don't remove it. I can't recollect any.
Yeah. So you see, we have a more robust evidence for rectal cancer, guidelines for not operating, but breast cancer, it is still evolving. We have MD Anderson trial where they have attempted just a core biopsies, targeted core biopsies to prove pathological CR and follow up. So currently it is not standard of the care. Okay. So how much volume you are going to resect if it's a complete pathological response, clinical response?
Concentrically as little as possible around the clip.
Okay, very political correct statement. Great. All right, Dr. Vijay, let's move on.
So the clip had been placed, a wire has been placed to localize the clip, and the tumor has been widely excised. Again, we remove a sliver of skin just for orienting the specimen, short stitch superior, long stitch lateral. You already know this. You have replied to all these questions brilliantly before. So we now move on to, we also did a specimen mammogram. That's the clip in the center. That's the wire. And again, no microcalcification, and adequate surgery has been done as per our expectations. So how will you address the axilla? So will you do a axillary lymph node dissection, or would you like to do a sentinel node? She was N1 disease, remember. One quick answer, Manthan.
Sentinel lymph node, sir. If the lymph node has been responded to chemotherapy, then sentinel lymph node.
Nishta, your answer.
Sir,
N1 disease, excellent response on sonography, no evidence of metastatic node.
Sir, ALN, I would go ahead with axillary lymph node dissection because SLNB in a post NACT axilla is still investigational under the setting of a clinical trial.
One expert comment from Neeta.
Why did you clip the node then, Nishtha? So you have to be very
No, we have
careful.
not clipped. I did not clip the node.
She wanted to clip the node.
Yes, you want. This patient belongs to me.
So
she
the
is
node,
not in
yeah.
charge.
So I'm going to be honest. N1 disease, currently the role of axillary conservation is taken with a bag of salt. Be careful, choose your patients accurately, target your lymph nodes appropriately and try and do it. Otherwise, most of us will be doing ALND. You could do low axillary sampling. That's an option in these because it gives you a higher yield of number of lymph nodes, which allows you to have a better false negative rate.
So I
Dr.
hope all the trainees have got that very clear message from Neeta. So she has some residual disease, some in the breast. All the margins and base are involved. All the lymph nodes were negative. We did an axillary lymph node dissection. She has residual disease. So Manthan, I come back to you. Of course, she will need adjuvant radiotherapy.
Radiation.
But what you remember that she had received 6 cycles of TCHP. So what are her options for the adjuvant systemic treatment?
For the adjuvant systemic treatment, she has a residual disease post trastuzumab and pertuzumab. So I will like to go ahead with the TDM1 in the adjuvant setting. And along with that, she is ER positive. So along with that, hormonal therapy in the adjuvant setting.
So what's the clinical trial that justified the use of TDM1 trastuzumab deruxtecan in the post-neoadjuvant setting?
CAT3 trial.
Excellent. And hormone therapy. Okay.
Hmm.
Would you want to treat, add anything else in the hormone therapy to these patients, considering her to be a high risk patient?
Sir,
Uh,
she has
we can
been
add
proven to be BRCA positive, BRCA1 positive based upon the previous report that you showed us.
Yeah.
So there is there is benefit of adding
capacitor.
PARP inhibitors. We can add PARP inhibitors in BRCA1 positive germline patient, germline mutation patient.
Anything else, think simpler. So there's nothing wrong with the
Capacitor.
PARP mutation from the Olympia trial. Think simpler. He's asking you, young lady has a node positive disease post chemotherapy, has high risk disease, is ER positive. Along with hormone therapy, would you like to give her something else?
Any role of
Uh,
ovarian suppression?
Capecitabine.
Yes,
Ovarian
ovarian
suppression.
suppression.
So the soft
Capecitabine is for
and
triple negative
trial.
breast cancer. So that is the CREATEX trial. So that is not an option in this particular patient. Please read the options that are available. NCCN table is there, post NACT, residual cancer burden, RCB 1230. What are your options? Very clearly defined for HER2 positive, hormone receptor, TNBC. All, just you have to mug them up and be bang on target. Now remember that she's HBOC positive. Nishta, how surgery has been done, radiation has been given, everything. The family is very happy. You've done a great job. Quick answer: surveillance for HBOC.
I will survey her with the MRI and a mammogram annually.
Every 6 months, 6-month MRI, 6-month mammo.
And after BCS, the minimum interval required is 6 months, but annual mammography and MRI.
Okay.
What is the
about
role of CA 125?
She should undergo a routine pelvic examination, but as such, CA 125 and USG abdomen and all are not recommended.
So what is the risk of developing ovarian cancer in BRCA1?
It is around
And what
15
is
to
the risk in
40%.
BRCA2?
It is around 15 to 25%. Lower in BRCA2, higher in BRCA1.
40% in BRCA.
I think the students have done extremely well. We have still the expert talk that will answer many of these questions by Professor Dev. So on behalf of my two examiners and the IASO, I thank both of you and the audience and the experts. One last takeaway is that you could also be counseling. Once she is BRCA positive, it also carries for the family. So you need to counsel her mother and the rest of the family as well. So all of them.
Thank you.
Srijan, can we go back to?
Yeah. Thank you so much, Dr. B.J. Vijay, Dr. Neeta Nair, and Dr. S.S. Dev, along with the examinees, Dr. Manthan and Dr. Nishta. Now we move on to the next segment, which is the expert talk by Dr. S.S. Dev. And the Q&A section will follow after that. We request everyone to stay tuned for that as well. Over to you, sir.
Thank you, Srijan. Thank you, Dr. Vijay, Dr. Neeta, for a fantastic session of 2 cases. I think both the candidates did well. I request both of you to maybe address the Q&A in the chat box and Q&A, Dr. Neeta and Dr. Vijay. Meanwhile, I'll just try to give an overview of early breast cancer. So if you look at the landscape of breast cancer currently, it is the leading cancer globally in 154 out of 180 countries. You see the entire pink, that is the sort of a footprint of breast cancer across the globe. And on the left side in India, currently breast cancer is the leading cancer in 26 out of 29 states in India. It is number 1 or number 2. It's the leading cancer. And we on average see around 1.5 to 2 lakh breast cancer cases, new cases diagnosed every year in India. And it constitutes around 27% of the overall cancer burden right now. And 1 in 28 urban women can develop breast cancer. We have seeing a relatively younger age of breast cancer compared to the Western population. And the frequency of early breast cancer versus LABCs versus metastatic is around 35, 50, and 15%. but this is the National Cancer Registry data. But we have witnessed a recent increase in the early breast cancers, especially in big metros, because of increasing awareness, patients coming for opportunistic screening, and access to investigations like ultrasound and mammography. So we are seeing more of T1 and T2 in the last 1 decade. Coming to recent advances in the staging of breast cancer, so the American Joint Committee, you all are aware of TNM staging. We have been using for the last 80 days. It's mostly based on the size of tumor. It is called anatomic staging or morphometric staging. But what happened in the recent 8th edition of TNM, which was launched in 2017, so it has been shown that breast cancer is now considered a group of diseases with different molecular characteristics. And the committee has recommended to incorporate biomarkers, including histological grade, hormone receptors, HER expression, and multigene panels into the traditional anatomic TNM staging. So this is the recent advance in the 8th edition TNM staging. So we are including the IHC markers, and if possible, if available, if patient can afford, even multigene panel is also integrated into the staging system. So what are the basic staging systems for breast cancer? We have a clinical staging, which we have been using routinely, which includes a clinical assessment, looking at the size of the tumor and extent of the nodal involvement, along with imaging. That's called clinical staging. And if you add the pathology information, that is the biopsy and IHC marker, it is called pathological staging. And the current prognostic stage grouping includes the biomarkers plus pathology. And the gene signatures, once you incorporate them into the routine clinical staging, then you have the molecular classification and staging of the breast cancers. So this is how you describe early breast cancer. Stage 1 and 2, up to stage 2B, we call it early breast cancer. Stage 3 is defined as locally advanced, and stage 4 as metastatic breast cancer. So what has happened recently after the 8th edition of TNM staging, once you start incorporating the biomarkers and gene signatures, so you have a prognostic staging, you have anatomic staging. So there are a few examples, like you have a patient of T2, N0, M0, ER positive, PR positive, HR negative, low risk oncotype DX. Anatomic stage is 2A, but once you integrate these biomarkers and gene scoring, it is downstage to 1A. So now the treatment wise, prognosis wise, it is 1A. So if luminal patients with who are HER negative with a low risk on oncotype DX, they get downstaged in the prognostic stage grouping. And we have similar sort of a classifications comparing anatomic versus prognostic staging. And there will be mostly a downstaging in the prognostic stage when the patients are ER/PR positive and HER negative. Suppose if the patient is triple negative, the patient gets upstaged. Even though the anatomical stage is 2B, but if it is a triple negative, in the prognostic stage, it becomes 3B. So just remember that in the prognostic stage grouping, currently we are including biomarkers and gene signatures. So I will not go into the details of this chart where we have various biomarker integration and gene signature integration into the anatomical staging, which will give you the final prognostic stage. A few words about molecular staging, which has become routine for breast cancer staging, prognostication, and treatment planning. This has happened because of the advances made in the field of breast cancer genes, the complete genomic profiling, and the outcomes have been evaluated. And 2000, that was the landmark year, where the paper was published in Nature Journal by Peru, where they have used a 476 intrinsic gene set selected based on the hierarchical clustering method. And this is what they have seen, the footprint of breast cancer based on the gene expression profile of these 476 genes. And they have divided these breast cancers and given the foundations for molecular classification of breast cancers. So it is not possible to do these 476 genes in all patients in routine clinical practice. So what has been done is to use the surrogate IHC marker, which have been approximated to the gene profiling. And now we have classifying breast cancers in your routine clinical practice based on the expression of ER, PR, and HER into luminal A, luminal B, which includes luminal A is CRPR positive, HER negative. Luminal B is of two types. Either it can be high Ki67, more than 14, or HER positive. Then pure HER positive patients, and triple negative. Triple negative can be either basal or non-basal based on the expression of EGFR and CK5 and 6. And you have luminal Bs also. So this is the basic molecular subtyping, which is routinely recommended in your routine clinical practice. That is why in all core biopsies, we go for ERPR and HER evaluation along with Ki67. If you look at the evolution of management of early breast cancer, we have three distinct periods in the last 100 years. Till 70s, we had in the era of radical therapy. So one size fits all, that was the concept. So every patient received radical surgery in the form of radical mastectomy or modified radical mastectomy, even for EBCs, followed by radiotherapy and systemic chemotherapy. With the introduction of multimodality therapy, the concept of organ conservation and biomarker introduction that has happened in between 70s and 80s. So there we started looking at the endpoints, not only on survival, but quality of life. Currently, we have entered the era of precision and personalized medicine in the last 20 years. So we have a lot of advances made in the field of breast cancer. We are using biomarkers and tailoring treatment to the individual patient and to the individual tumors. So we have moved from era of carpet bombing to precision medicine. And the lessons we have learned is big surgery and chemo-RT to all patients does not translate into big cure in all patients. So the current treatment philosophy is to shift from maximum tolerable therapy to minimum effective therapy. That is what you need to plan in your clinics routinely. What is the minimum effective therapy this patient is require, rather than bombarding every patient with standard radical surgeries and chemotherapies and radiation to all the patients. So we have entered the era of optimization and de-escalations. So these words are important for postgraduates. You may get short questions during the examination. So what is treatment optimization and de-escalation? Because breast cancer is the prime example of treatment optimization and de-escalation. So that is where you are trying to avoid unnecessary treatments. So these are the major landmarks of modern breast cancer surgery. Started with radical mastectomy. Then we moved on to modified radical mastectomy. We have realized we are overdoing surgeries. Then we entered the era of breast conservations, the golden period of 80s. Then we introduced breast reconstructions, sentinel lymph node biopsy, oncoplasty, risk-reducing surgery. If you see the entire evolution, we started from radical mutilating surgeries to organ preservation, organ reconstruction, treatment de-escalations. We are now going to for sentinel lymph node biopsy and improving the quality of life by offering oncoplasty. And we have moved to prevention of cancer, that is the era of risk-reducing surgery. So what are the factors that have contributed for the change in treatment approach? So we have a better understanding of the tumor biology now, a lot of awareness, screening and downstaging, advances in imaging, systemic therapy, radiotherapy, and clinical trials. I think they have played a pivotal role in the field of breast cancer, where we have a lot of landmark randomized trials, including the field of breast surgery and surgical leadership, and your willingness to change and introspect. I think most of these trials were led by surgeons, even the systemic therapy trials in breast cancer and organ conservation trials, all were led by surgeons like Varanasi, Bernard Fisher. So what are the current aims of treatment? When you see a patient of breast cancer coming to your clinic, so you need to tailor your therapy to patient and the tumor, attain maximum benefit and survival, avoid over-treatment or unnecessary treatment. You do a risk versus benefit analysis and use evidence from trials and predictive and prognostic markers and try to optimize your treatment to that particular patient. So these are the set of goals you need to follow when you treat a patient of early breast cancer in the current era. So breast cancer, again, is a great success story in the history of modern oncology, and it is a role model for all of the solid tumors because it is the leading field which laid the foundation for clinical trials, and it pioneered multimodality management And it is the area, I think breast cancer gave the prime example of organ conservation, de-escalation. And we also show how to collaborate, cross-collaborate and integrate molecular biology and genetics into surgical field, and cross-collaboration with plastic surgery. That is, I think, again, a game changer, the field of oncoplasty. And overall, you have a patient-centric approach. The patient is in the center. And it is an excellent model for all other solid tumors. Most of the advances in the field of oncology happen in breast cancer first, followed by other solid tumors. So the modern breast cancer management is a multidisciplinary treatment approach. So all the postgraduates must remember, either you should have some sort of a team you try to develop when you go and practice. Try to develop a small core team of either a tumor board, whatever you call disease management group, or MDT. So it has to be multidisciplinary team. It is not a solo practice anymore. And you keep the patient in the center, and you have a core team of surgeon, medical, radiation oncologist, pathology, and radiology in the inner circle, followed by a number of various supportive specialties like psycho-oncologist, fertility expert, palliative care expert, nuclear medicine. So these are all called non-core teams. So this is the ideal sort of a team which needs to be built up in the modern era of breast cancer management. It is not just learning from sentinel node biopsies or oncoplasty and going practice. So when you start your breast cancer practice, you try to develop these setups, maybe a small core team, then have a MDT discussions routinely. So what is the mandate of MDT? So you need to, I'm just dwelling a little bit because you will be practicing in oncology in comprehensive cancer centers. A surgeon should know the mandate of MDT, and you should lead the MDT programs as a surgeon for solid tumors. So these are meant for joint treatment planning, shared decision making, well-defined treatment goals. We have well-defined individual jobs, treatment coordination for timely treatment delivery, joint follow-up, and rehabilitation. So these are the main aims of MDT. These activities needs to be coordinated by MDT. So coming to the breast cancer management, you have a long trajectory of a breast cancer patient. They go through a long treatment, different phases, and also they come for follow-up for a long time. So you have different requirements, different needs at different stages of management, starting from screening, diagnosis, treatment, which includes planning, execution of treatment, counseling regarding goals of therapy, psychosocial counseling, fertility and sexual issues, familial and genetic aspects. You need to just have a checklist in your clinic, all the postgraduates. So what all needs to be done when a patient of early breast cancer comes to your clinic. And during follow-up and surveillance, we need to look at the rehabilitation part, management of treatment-related toxicities, and also look for any evidence of relapse or second primaries. So what are the current breast cancer treatment options? You have a plethora of options in the current breast cancer practice for early stage breast cancer in MDT clinic, starting from surgery to systemic therapy to radiotherapy. I will dwell upon a little bit in detail regarding each modality. So you have various surgical options based on the tumor, patient characteristics, patient needs, and we have various systemic therapy options, including chemotherapy, hormonal therapy, targeted therapy. Now we have immunotherapy also coming very rapidly in the scene for breast cancer management. And radiotherapy field is also evolving significantly during the last 2 decades. The standard workup includes triple assessment, which includes clinical, imaging, and biopsy. Staging we have discussed in our case presentations. A routine metastatic workup is not required in early breast cancer patients. Of course, there are few exceptions. If the patient is symptomatic, or if you're dealing with maybe aggressive phenotypes like TNBC or HER positive breast cancer patients, you sometimes do metastatic workup. So what is the role of MRI and PET scan? So again, MRI is currently being overdone in clinical practice. It has specific indications, especially in patients with dense breasts, inconclusive mammograms, if the patient had prior breast conservation or breast reconstruction, if there is a family history of breast cancer, or if you're dealing with a patient with unknown primary, or if you're planning neoadjuvant therapy. So these are the common indications for MRI of the breast. PET scan is routinely overused in clinical practice. It is not routinely recommended. It is basically used for staging advanced and recurrent breast cancers when the conventional imaging is equivocal. And currently, there is evidence emerging that it can be used as a single staging modality for LOBC or LABCs. Coming to principles of management of early breast cancer. So you need to address the local regional therapy and systemic therapy using various modalities. So management of early breast cancer, the traditional treatment pathways. So we have two major pathways. One is upfront surgery followed by adjuvant therapy. The second pathway is neoadjuvant therapy followed by surgery and adjuvant therapy. So these are the two main pathways you need to decide in MDT. What are the common indications for neoadjuvant therapy in early breast cancer? Normally, neoadjuvant therapy is used in locally advanced breast cancer patients, but there are certain situations in early breast cancer where you can opt for neoadjuvant therapies. So those indications include large operable breast cancers, especially T3s, not suitable for upfront BCS. Triple negative breast cancers, more than 2 centimeters in size, which are node positive. HER positive breast cancers, more than 2 centimeters, which are node positives. And sometimes if the patients are undergoing genetic counseling or testing, you need time to take a call. We can also go for neoadjuvant chemotherapy and wait for your surgical decision till we get the genetic testing report. Management of early breast cancer for stage 1 and 2 for luminal subtypes, especially ER/PR positive, generally we opt for upfront surgery because these are not chemosensitive, and followed by adjuvant therapy. And breast conservation therapy is the treatment of choice for majority of the patients if they fulfill the criteria. For T2, T3 EBC patients with poor tumor breast ratio or a phenotype of TNBC or HER positive, normally we go for neoadjuvant therapy followed by breast conservation or mastectomy, depending on the response. In the early breast cancer, with increasing awareness and screening, a lot of patients are nowadays coming with non-palpable breast cancers. So this again is increasing the challenge for operating these patients because it is difficult to operate on patients who are screen detected compared to patients who come with palpable tumors. So we need to use a lot of technologies or techniques to localize the tumor and get rid of the early non-palpable tumors. The most commonly used technique is wire-guided localization. And a lot of new technologies are coming, which includes radioisotope-based techniques, which is called ROLL, and all these lesions. And we can use intraoperative ultrasound. So you must be familiar with these technologies for managing non-palpable breast cancers. So this is an example of wire-guided localization. Traditionally, the J-wire or hook wire is what we call this. And these are used for non-palpable breast cancers. Coming to surgical options, where do we stand for early breast cancer? Till 80s, the only option of surgery was radical or modified radical mastectomy with the ALND. But now we have more than 30 different types of surgeries that can be offered for early breast cancer patients, including various types of mastectomies, breast conservations, oncoplasties, and sentinel node procedures. The surgical options include breast conservation therapy, either upfront or post-neoadjuvant, breast conservation along with oncoplasty. The other major surgical pathway is mastectomy. Either you go for a modified radical mastectomy or skin sparing or nipple areola sparing mastectomies with or without reconstruction based on the needs of the patient and your case selections. So what are the factors that can affect your surgical decision making? So you need to look at the tumor related factors first because you cannot compromise on them. So that includes the size, the location, multicentricity, stage, tumor versus breast ratio, and molecular subtype. Remember, you should have a checklist in your clinic. When you check the tumor, these are the factors you need to assess before you decide whether you want to go for breast conservation or mastectomy. Patient-related factors include the age, the desire, the marital status, the socioeconomic factors, family history, and BRCA status. Remember, you need to assess all these factors when you plan to decide whether to go for breast conservation or mastectomy. The third most important factor is the treatment-related factors, which include the expertise available at your center, including your surgical expertise, your familiarity with oncoplasty, your radiotherapy facilities. These are also important factors, whether the patients can come for follow-up or not. So these are important factors you need to look for before you decide whether to go for breast conservation or mastectomy. Coming to the primary surgical options, mastectomy versus breast conservation, you can see the difference is obvious. The cosmetic and functional outcomes of a patient undergoing breast conservation are far superior to a patient undergoing mastectomy. So breast conservation is now more than 3 decades old. It is most scientifically studied and validated therapeutic intervention in the field of oncology, starting from retrospective studies, landmark randomized controlled trials. Now we have more than 25 years of long-term follow-up available for breast conservation, and it has proven that BCS is the treatment of choice for all suitable early-stage breast cancer patients. But of course, breast conservation rates vary widely across different regions and across different countries. Especially, we have low breast conservation rates in India, mostly because a lot of patients come with advanced stage of disease, and because of resource constraints, radiotherapy access is difficult. So majority opt for mastectomy because of convenience. So the reasons for low BCTs include it can be surgeon-related factors, resource-related factors, or patient-related factors. So what are the recent advances in the field of breast conservation? Now we are integrating advanced imaging for breast conservation, including MRI, tomosynthesis, elastography, integration of pathology and biology, various molecular subtypes, and integration of genetics, integration of modern chemo-targeted and hormonal therapies. A lot of these factors will influence your surgical decision making. So that is why we don't jump. Once you see a patient of early breast cancer in the clinic, on the day one, you don't take a decision. You need to do your clinical assessment. You need to do your radiological assessment. You need to talk to the patient in detail what exactly she wants, get all the pathology information, molecular information. Then you are at a right position to take a call. What is the right surgical option for that particular patient? So there are certain advances which have happened in the last decade to expand the indications for breast conservation therapy. These included a neoadjuvant therapy followed by breast conservation, and the second game changer was oncoplastic breast surgery. So a lot of patients who are not suitable because of the tumor breast ratio or large tumor size were denied breast conservation earlier. But the landmark trials, the NSCBP 18 trial and EORTC trial have shown that if you offer them neoadjuvant chemotherapy, especially for large operable breast cancers, you can convert mastectomy to breast conservation in a significant number of patients. Almost 30 to 40% of patients who are undergoing mastectomy can be converted to breast conservation therapy by using neoadjuvant therapy. So this has become a standard now. Of course, you need to follow a set of protocol in patients undergoing neoadjuvant chemotherapy followed by breast conservation. A good imaging, a good pathology service, a good imaging interventional radiologist who can localize your tumors, and of course, your surgical expertise is extremely important. And last but not the least, a good pathology backup is extremely important in evaluating the specimens following neoadjuvant chemotherapy and breast conservation surgery. So these are few examples of NACT. You can see a poor tumor breast ratio in this patient on the right side. So you can go for neoadjuvant chemotherapy. The patient has almost achieved a complete CR, and we could do an excellent sort of a breast conservation. So the third pathway which has opened up, apart from the mastectomy and breast conservation, in the last 2 decades is the oncoplastic breast surgery, which is a combination of partial mastectomy and partial breast reconstruction. So oncoplastic breast surgery is commonly used in the context of breast conservation field, where we use a combination of plastic surgical techniques to achieve good cosmetic outcomes following breast conservation surgery. So on the left, we have pictures of traditional breast conservation outcomes. So sometimes you have skin loss or cavities, which can result in inferior cosmetic outcomes. But by using the oncoplastic techniques, we can achieve excellent cosmesis as seen on the right side of the slide. So these are the current era outcomes following breast conservation therapy. So I will not delve into the details of breast oncoplasty. It is a separate complete lecture altogether. So there are various techniques based on the quadrant-wise location of the tumor and the size of the tumor, type of the breast. You have various techniques described, various types of oncoplasty for early breast cancer. So these are few examples here. The upper inner quadrant, we did a J oncoplasty here for a young patient, and we could achieve good cosmetic outcomes. For inferior pole tumors, either you do an inverted T approach where you can avoid bird beak deformities, and in a large volume loss, we can go for volume replacement by using LICAP flaps or LD flaps. LD flaps we are not using nowadays much, but it's mostly perforator flaps for volume replacement. So the OPBS, that is oncoplastic breast surgery, is the standard of care, and it has been integrated in breast cancer surgery field now as a standard of care. And the proven benefits of oncoplastic breast surgery include increased breast conservation rates, improved cosmetic outcomes, decreased margin positivity, decreased re-excision rate, and good patient-reported outcomes, that is PROMs. So these are all proven benefits of oncoplastic surgery in the current era. And a few words about modifications of mastectomy. Traditionally, we have been doing modified radical mastectomy, but in the last decade or so, we have come out with various modifications of mastectomy, including skin sparing, nipple areola sparing mastectomy, areola sparing, and skin reducing mastectomies. So these all have mostly a cosmetic sort of a basis for doing these procedures, especially in patients who are not suitable for breast conservation. We offer these procedures along with breast reconstruction, and you can achieve excellent cosmesis by doing autologous or implant-based reconstruction following these types of mastectomy. A few words about axillary lymph node management in early breast cancer. So these are the three pioneers who have actually changed the field of axillary lymph node management in the last 100 years. William Halsted, who laid the foundations for ALND, Bernard Fisher questioned the role of ALND, and Armando Giuliano, who has introduced sentinel lymph node biopsy. So now we have very clear-cut guidelines how to manage lymph nodes in early breast cancer. ALND is no more the standard of care, especially in node-negative early breast cancer patients. You have to do a sentinel lymph node biopsy. And in node-positive patients, it is recommended to go for level 1 and 2 axillary lymph node dissection. So there are various techniques of sentinel lymph node biopsy we have discussed during our case presentations. Commonly, you should use a dual technique, either using a blue dye with isotope or ICG. And axillary nodal assessment, currently you need to do a good clinical assessment along with a good ultrasound of the axilla is mandatory. And if you have good expertise, you can also go for ultrasound guided FNAC and clip placements. Otherwise, a good clinical assessment and good ultrasound assessment is mandatory. A few words about radiotherapy in early breast cancer. It is an integral part of breast conservation therapy, and it can decrease the local recurrence by almost 50%. So routinely, we should offer radiotherapy following breast conservation therapy. Post-mastectomy radiotherapy indications, T3 tumors, positive margins, more than 4 nodes positive, extracapsular spread, and 1 to 3 nodes with high-risk features. All these are indications for post-mastectomy radiotherapy. Regional nodal irradiation, again, either it includes infra or supraclavicular fossa and internal mammary nodes. And this is indicated in node-positive patients, especially 1 to 3 with high-risk features, T3 and T4 primaries, T2 with inadequate ALND or any one of the high-risk features. Axillary radiotherapy should be avoided at any cost, otherwise it increases the risk of lymphedema. Now we have a lot of new advances that have happened in the field of radiotherapy for early breast cancer, including hypofractionated radiotherapy. We have a lot of trials coming from UK, short duration, just 3 weeks of radiation. And we also have intraoperative radiotherapy for very favorable tumors, and APBI, that is accelerated partial breast irradiation, where you have decreasing the duration as well as the size of the field of the irradiation. And so these are few recent advances in the radiotherapy for early breast cancer. And this is an example of intraoperative radiotherapy using Golgi's system, intrabeam system. A few words about systemic therapy. A majority of the breast cancer patients will require systemic therapy in the current era in the form of either chemotherapy, standard or targeted therapies. Currently, we have established therapies in the form of Herceptin, pertuzumab, PARP inhibitors, and immunotherapy is rapidly emerging, especially for triple negative breast cancers. Recent trials have shown a substantial benefit in TNBC patients using immunotherapy. So these are few broad recommendations based on the molecular subtypes. For luminal A, we use endocrine therapy alone in most of the patients. And in high-risk luminal A, we also add chemotherapy. Luminal B, that is HER negative, we use chemotherapy along with endocrine therapy. Luminal B with HER positive, normally we use chemo along with anti-HER therapy, followed by endocrine therapy. HER positive tumors, it's very clear-cut treatment guideline, use chemotherapy along with anti-HER therapy. The gold standard is Herceptin, and currently we are adding a dual targeted along with pertuzumab. Triple negative, the traditional chemotherapy regimes we commonly use, and mostly nowadays we use platinum-based regimes. And immunotherapy is coming rapidly in the field of TNBCs. These are certain indications of chemotherapy and trastuzumab based on the tumor size and nodal involvement. And for hormonal therapy, premenopausal and perimenopausal, the first choice is still tamoxifen, and with or without ovarian suppression. Based on the soft and text trials, we add ovarian suppression along with tamoxifen for premenopausal patients. For postmenopausal, the gold standard is aromatase inhibitors with switch therapy to tamoxifens. Last few words about multi-parameter gene signatures. In early breast cancer, you have already discussed, we are in the era of de-escalation. So how to de-escalate, whom to de-escalate, and when to de-escalate, you define these issues based on the clinical features. And we also sometimes resort to the help of multi-parameter gene signatures. The most commonly used gene signatures include Oncotype DX, MammaPrint, EndoPredict, and CanAssist, which is Make in India gene signature. It's IHC-based parameter. Oncotype DX is widely validated for taking decisions regarding the benefit of chemotherapy in luminal A patients who are node negative and HER negative. So that is the subset of patients where you can try Oncotype DX and see the risk of relapse without chemotherapy. This is a CanAssist. We are using a low-cost alternative, Make in India gene signature. And these are few recent updates on systemic therapy. You use for HER positive EBC, we use Oncotype DX. HER positive MBC, we use upfront CDK4 and 6 inhibitors. And HER positive, we have started using dual targeted therapies, and we are introducing TDM1 in adjuvant setting with residual disease. And for TNBCs, we are going to neoadjuvants based on platinum, and immunotherapy is currently being used in the locally advanced stage in the adjuvant setting. And capecitabine is, we have CreateX trial where it has shown following neoadjuvant therapy, if there is residual disease, capecitabine should be added, oral capecitabine as the standard of care. So this is the a summary chart, last slide. If suppose a patient of early breast cancer comes, so you need to do a standard workup. We need to have a good MDT discussion, and based on the tumor size, patient desires, molecular subtype, stage of the disease, you have various options, starting from upfront breast conservation to neoadjuvant therapy or upfront mastectomy, followed by various treatments. So all the postgraduates should be familiar with how to work up a patient of early breast cancer in the examinations, the standard triple assessments, and young breast cancers, node positive versus node negative, what are the recent advances we need to be able to answer. And oncoplasty also may be a point of discussion during examinations. For most of the postgraduates, we discuss these issues. And recent advances in radiotherapy and chemotherapy, you should be familiar. So to conclude my talk, early breast cancer, I think, is a multidisciplinary treatment approach, tailoring the treatment and surgery according to individual patients and tumor profile is the key to success. So everybody should know the basics of not only surgery, but you need to know a little bit of radiology, pathology, molecular biology, systemic therapy, and radiotherapy as a surgeon, if you really want to offer ideal treatment to a patient of early breast cancer. So with that, I would like to conclude my talk. Thank you very much.
Thank you, sir. We move on to our next segment, which is Q&A with the experts. Now, what I would request everyone is, even after the Q&A is done, there are many questions which have already been answered on the Q&A section of this Zoom. So take time, because both examiners, Dr. Neeta Nair and Dr. T.J. Vijay, have really patiently answered each and every question which was put up and in detail. So lots to learn there. What I have done is I have put up few of those questions and put it on the slide here. I'll request Dr. S.S. Dev sir and Dr. Neeta ma'am and Dr. T.J. Vijay, if he's still around, to kindly go through these questions and offer any other clarifications or information needed from their side.
Thank you. Thank you, Srijan. Dr. Neeta, are you around?
Yes, sir.
Yeah, so we can take these questions. Maybe you can start, Dr. Neeta, the first question.
The core biopsy question is the most appropriate way would be to do it USG guided. But in case you don't have access to it, then you use the center of the tumor as your target and you place your core site over that.
Yeah. So I'll take the next one. What is the relevance of population-based screening mammography in Indian society today? So we are not ready yet for population-based screening because we still not considered as a high-risk incidence breast cancer like Western countries. We are at the intermediate incidence right now. And the logistics of doing a population-based cancer screening using mammography, the number of mammography units required, the number of radiologists required, and the number of biopsies required. We need to have complete infrastructure if you want to go for population-based cancer screening using mammography in India. So currently what we are recommending at a national level as a policy is breast awareness. That is more important, breast health awareness and early detection by clinical examination, but not population-based screening using mammography. Neeta, you can take the next one.
So the next question is for triple negative. Is there a size criteria for which upfront surgery can be considered? So I'm going to be honest and say that if you have breast tumor ratio that allows for an upfront BCT, that size could be anywhere from 2 to 3 centimeters. There isn't a cutoff. The concern that's raised is because now from T1C onwards, there are recommendations that suggest, based on risk-adapted treatments using chemo first and then offering capecitabine in the adjuvant setting to those who don't respond. That's what's created the confusion. But that against doing straightforward upfront wide excision with good axillary staging, honestly, and this I'm going to say is that is very personalized and is very individualized by most of us, but up to about 3 centimeters in a node negative, many of us would consider upfront surgery.
Thank you. Thank you, Neeta. The next question is internal mammary lymph nodes is suspicious on CT or PET CT. Should we do FADC and its impact on management? Dr. Neeta, would you like to respond?
So I think if you have an IMLN on CT or PET CT, it's automatically considered as radiologically positive and it becomes N2B. The point here is that how do you address it after chemotherapy? And after neoadjuvant chemotherapy, if you still have residual IMLN, you may want to do either a wax dissection or a Chamberlain's open technique. Otherwise, you will always radiate that space anyway. And even if you've operated, you will be radiating the IMLM.
Thank you. Thank you, Dr. Nita. I will take the next one. The patient is BRCA positive and has children. Should we offer them genetic testing right away or wait? So this is a difficult question in the clinic when you see a patient who is already diagnosed with breast cancer and BRCA positive. They're worried about their children. So we normally don't jump and test the children if they are very young and minors. So first you handle the patient, explain the pros and cons of genetic testing and what are the implications, the social implications, psychological implications. Then once they mature enough and understand, then we recommend the testing for the children at a little later age, once they cross 20 to 25 years of age. Once they understand the implications, then only we go for genetic testing. We don't jump for testing the minors, but we need to discuss the implications with the index patients and the parents. Neeta, would you like to add anything to this? Or
Perfect.
Thank you. Thank you. So the last question here is, during prophylactic mastectomy, should we do a sentinel node for axilla? Neeta, would you like to respond?
I'm going to say no, because we hope that you have done an MRI and you would have picked up any small occult foci. The concern is that if when you process that prophylactic mastectomy specimen and you find the focus of cancer, your worry is then how do you stage the axilla? And I'm going to say go back and do a quick low axillary sampling that's simpler, but do not prophylactically address the axilla for patients.
Absolutely correct. So we should not, you see, you should have a good quality imaging. If it shows no evidence of any disease, we should avoid any axillary interventions. Well, any other questions or any other comments from the experts? Dr. Rao is here, Dr. Rudra, Dr. Sharath. Anything you want to add?
No, sir, I think it was superb. Both the students were very good, and all the questions, I think every aspect is answered. And breast is large, actually very big topic.
Subject, very vast.
So I think in one go to finish everything is superb, actually. Concise, and every aspect was touched in the examination, investigation, treatment, and everything. I think nicely done by both the students and the faculty.
Thank you. Thank you, Rudra. Thank you. Any other comments, Dr. Sharath or?
What you mentioned, that we have to make the breast awareness, that is one of the most important things. So, and the availability of treatment for breast cancer, if it becomes more easy, then people tend to come in early stages. Because I stay in a very small town, in a very simple taluka place, and I see that around 60% of my patients are early breast cancer, which is very different from what when I hear the people from the metros say that. So I think that is because, I mean, it's we have got the facilities, and because of this Ayushman Bharat and other schemes, it has become cheap. People tend to detect it early. If they are aware, they tend to come quickly. So that is probably more effective than doing mammography in our patients.
Thank you. Thank you. Thank you, Dr. Sharath. Any comments or feedback from the candidates, Dr. Nishta and Manthan? So are you satisfied with your performance?
So that is for the examiners to tell, but it was a great learning experience. So thank you, sir.
Manthan?
Yes, sir, great experience, but I think I can improve on some parts. That's all.
Yes. Yeah, you did reasonably well, both of you. All the basic, I think, issues you reasonably covered well. But breast cancer is a very evolving field, fast evolving field. But you need to, for examination point of view, I think you should focus on good clinical assessment. That's extremely important. And basic management approach, principles, rationale, why you are doing that, and little bit of evidence. So that is what is needed at a level of postgraduate. That is what normally the examiners expect. So congratulations to both of you. And I would like to thank Dr. Neeta, Dr. Vijay, and all the office bearers of IASO who have sitting through for the last 2 hours on a busy weekday. And I would like to thank the Indo-American Cancer Center, Dr. Rao and Dr. Srijan for spearheading this masterclass for last two, I think since COVID, I think we started. Thank you very much, Srijan. And I think if you are okay, we can conclude the session.
Right, sir. But from my side, I would like to thank all the faculty and examinees. One point was because of the format that we have, where we discuss 2 to 3 case scenarios. The intent is for the all the participants, all the students, as well as faculty, to know the different ways of algorithms that happen in clinical practice. However, in an exam, what will also be tested, which we are not testing here, is the comprehensive history taking and clinical examination skills,
Yes.
which come into play. And we have the first season, couple of seasons of Masterclass, which test only that. So go back and view those videos on YouTube as well, because there the more detail of history taking and clinical examination has already been discussed. And that's also another parameter which goes into learning. We can't do everything on one show in 2 hours. We just are trying our best. Thank you, everyone. The
Yeah.
next
Thank you, sir.
masterclass is going to be on 21st May, and the topic is going to be rectal cancer. We invite you all to attend that in a fortnight's time.
Great. Thank you. Good night, all. Thank you very much. Happy learning. Thank you.
Thank you so much. Good evening, everyone.
Thank you. Good evening.